Hi friends, this small presentation is just to show how to plan a transforaminal endoscopic surgery in case of a inferiorly migrated fragment. This is a 55 male with severe left radiculopathy. MRI is showing L4 L5 left disc prolapse with inferior migrated fragment just reaching the pedicle. So in such cases, ideal approach would be transforaminal. So in this case, I did a left-sided transforaminal approach. You can see for any beginner, the placement of cannula, that is the initial dilator placement, should be in the midline in AP view on X-rays, and when you see the lateral view, it should be in the posterior one side. If you follow this, most of the time we avoid injuries to the exiting nerve, and for a beginner it is always safe. So once this position is attained, the sleeve is placed, and whenever the sleeve is placed, in this case because it is inferiorly migrated, I just rotated the sleeve inferiorly. But here our fragment is more lateral, but at this position when you see after putting a endoscope at 12 o'clock you see the annular fibers. Here being a left-sided case, we are standing on the left side of the patient. So the 9 o'clock is superior or cranial, 3 o'clock is inferior or caudal. So you can see here, you see the annular fibers like this when you are in this position. But our position of the disc prolapse is more lateral. So we just withdraw the disc, withdraw the cannula further and check on the C-arm. So here you can see my cannula is just in the foramen and also in the lateral recess. So here we call this as half in half out technique, where once we reach this area you can see the endoscopic image. At 12 o'clock you can see the epidural fat nicely. In the middle of the image you can see the PLL along with annular fibers, and the 3 o'clock is the inferior end plate. Here we are more interested to work inferiorly at this point because the fragment is just skirting the pedicle, and if we imagine that when we superimpose the C-arm image on this, we can understand the fragment is just skirting the pedicle. So here we need to work more inferiorly at this aspect. So what I have done here is I'm just using a cutting punch or annular cutter and cutting the annular fibers inferiorly towards the lower end plate. This opens up the disc space to the epidural space so that we can work freely. Once you release the annulus here, you can see I am passing a hook and just hooking out the fragment. Because according to the MRI, the fragment is just adjacent to the pedicle, so our fragment should be here if our understanding is correct. But even if fragment has come out, we are not sure whether we have removed a complete fragment. So it is better to visualize and open up the lateral recess. So I am using a flexible or articulating burr to open up the lateral recess, confirming on the C-arm X-ray. So you can see this is a small video where you can see I am I've drilled the facet pedicle junction and opened up the lateral recess to expose the root nicely. The fragment is completely removed, the root is completely exposed and well decompressed. So this is the final image you see where the root is completely exposed and well decompressed. So this is the immediate post-op image where you can see the fragment is completely removed and the facet is not violated. Just a bit of superior facet is drilled and the complete fragment has come out. Thank you.